Hello, everyone, and thank you for joining our webinar today. Hopefully you can see my screen all right. Do let me know if you can't. Um, we're just going to wait for a couple of moments as we watch people come in. So, if you need to grab a small snack, a cup of tea, please do. This webinar is recorded and we will send it to you afterwards. And we'll have your email from the registration. So don't worry about putting it in anywhere or sending it to us, because we can definitely get that on its way to you with the slides as well. Still seeing those numbers climb up, so I'm just going to wait for a bit longer. If you want to let us know where you're dialing in from today, then please do. And any kind of particular concerns about winter pressures as well. Well, those numbers have slightly slowed down as we trickle through now, so we get to do a proper introduction to our webinar today, which is how Accurx can support with winter pressures. So there is our support team here as well, so they'll be able to answer any questions that you might have. So please do utilize the Q&A. Anything that might be coming up before we even begin the webinar, you can feel free to pop them in there. And we've also got Dr. Dave Triska on the call today, who's going to be talking about the context and some of these strategies. Mostly this has come from the brain of Dave. So yeah, really useful to have you here. I'm going to go over a quick agenda. So effectively, we're going to set some context of what winter pressures look like in practice, some examples, and equally a live demonstration of how you can use Accurx to kind of combat some of the pressure that comes about during winter. Equally, towards the end of the session, we've got a full Q&A type discussion, so we can share also a few reminders on where you can get support as well. First up, though, is you, Dave, if you want to take this away. And thank you again so much for joining us.
No, my pleasure. So I had a very apt start to the week this week, which I'm sure many of you shared with me as we saw a massive spike in winter viruses. So it was a memory of Christmases gone by as GPs started calling in sick before the day started. And it was fast and furious as we began the day with probably 20 to 30% more demand than we'd normally expect on a Monday. And that was largely through respiratory illnesses that come in these huge waves now. So the problems that we face each winter are there are predictable moments that we need to pivot around to make sure that A, we can get home in a good state, and B, we can provide some clinical care. These largely revolve around viruses, winter illnesses, and patient demand, amongst other things, but they're a significant pressure that's predictable. So although they happen at moments we don't know, we do know that they're going to happen. So this is something that is universal across it. So despite having that 20% greater demand, at least on Monday, and 2 GPs ill, we did manage to accustom the practice to provide the care we needed to. And that was largely through some of the techniques we're going to talk today. So Accurx, as you know, is all about communication. So a lot of this is about helping us communicate with our patients what's happening, how it happens, and what are the things that we're going to do to respond to those pressures when they come. So we're going to walk you through today some easy to use stages of communication that you can have both with clinicians, with patients, and how do we triage appropriately when we're overwhelmed and don't actually have physically enough people in the building. So we're going to take you through step by step, give you some examples of how you can use these tools and techniques. And then finally, at the end, we're going to provide some links to go through where we can join into our community forums, both on Facebook and elsewhere, and actually share some of those tools that we're using at the moment, including the questionnaires. Good enough for you, Hannah?
Absolutely. Do you want to go over the next slide as well? Or do you think, I mean, effectively, you've really kind of touched on a lot of this as well.
Yeah, it's a really important bit to talk about what do we do proactively and reactively in these situations. So I mentioned about Accurx being a communications company, and actually the way that we manage this is by communicating what's happening. So while it feels like it's overwhelming when people are dropping like flies, and that happens throughout the winter, actually having some conversations with patients about what's happening in the surgery is really, really important. So one of the very first things I did, apart from have a mild panic attack on Monday morning as people started calling in, was to start communicating out to patients. So you're aware that we have a number of different tools to do that, both on an individual basis and on a mass basis. And this is really, really important. So my finding over the last few winters using Accurx has been that when these events do happen, and as I say, they're predictable, they happen every winter, the more that I tell patients what is happening within the surgery, the easier my day gets. So if we don't actually communicate that we're having difficulties on a particular day and what they are, then patients won't understand why we do behave in a certain way, as in we need to be slightly more strict on triage, we need to allocate resources appropriately. So it's really important that we do that in a timely fashion. So it's no good waiting until the 8 o'clock rush has been and gone. By then, we've already been overwhelmed and we can't actually tell people what we need from them. I think it's really interesting that the more we communicate with patients, in my experience, the more they behave like reasonable humans to us. The less we communicate, the more they behave in a demanding fashion, which is very, very difficult to meet when we're under pressure. I mean, certainly Monday was a really good example. So telling people that we had clinicians that were ill, and as we were having to move clinics around and rebook people, which will show you the easy ways to do that. So we don't have to have a receptionist sat there just ringing 400 people or whatever it is on the day. People were very understanding. So actually explain to them, this is why we're doing this, this is what's happening, these are the ways that you can help yourself, these are the ways that we need to find out if you need to come in. It actually made the day really easy. So both me and the other GP that were in on the day got away at 6:30 p.m. on Monday afternoon, which I think, considering the influx and the outflux of GPs, was remarkable. And really this is about resilience for general practice. We know it's going to be difficult. We know it's going to be difficult this year particularly, although we do say that every year and it always seems to get worse. So we may as well protect ourselves from those pressures. We still have to turn up and do the day job, but we don't have to do it in that pressured environment that we do in an old-fashioned, less responsive and proactive way to these minor winter crises that we face every year.
Absolutely. Well, thank you so much for touching on all of those. And then, like I said, if anyone's got any questions on that or for Dave, please do put them in the Q&A. Do you have anything else to say, particularly on this bit, or shall I move on to a couple of examples and things like that?
Why don't we move through to the examples now, so we can walk through some of those. So I think they will illustrate in many ways much better than I can explain how we are going to do this. And then I think what we'll aim to do in the question and answers at the end, if people are happy to do so, is if you have specific cases within your practice or issues that you want to talk about, we can work through with the same kind of process that we're going to show you now, and then actually leave you at the end of this with some tools that you don't have to write yourself. So I'll explain at the end where I'm going to put those. And that means that hopefully by tomorrow, you'll have all of this in place for your practice and you can go away with some backup and resilience for the rest of the winter.
Well, thanks, Dave. I mean, I think this element, or this slide particularly, really is hammering home that point that you've made, which is communicating efficiently and asynchronously. The fact that you can easily contact patients about things like cancelled appointments, or even just kind of proactively reach out to them. One of the points that we've made here is to contact them using Accurx batch messaging. So if there's a cancelled clinic or a cancelled appointment, then you can do it through there. And then equally, if there's staff absence, you can then send it through that batch message function, rather than having to call up, like poor Kermit here, each patient, potentially ask them to rebook, because then you can use self-book to allow patients to actually rebook themselves and amend that from there. Equally, using online consultation allows the practice to kind of reduce inbound on the phone lines as well. So if you've got reduced staff, so reduced reception staff, for example, and that phone queue is getting longer and longer, being able to direct patients either via a hold message or just because they're used to using online consultation can be really useful, and then allows you to kind of triage most effectively based on need. Equally, this also gives you an opportunity to understand and manage that demand. So if patients are getting in touch over what might be considered a minor illness, if they're calling in and that is just automatically being booked an appointment, that can be really difficult to actually mitigate against those unnecessary appointments that maybe could have been directed elsewhere or potentially even handled asynchronously. So our focus today will also be to reduce a kind of capacity burden using a triage system, making sure that patients get the care that they need at the right time and based on that kind of clinical urgency as well. Equally gathering information about a condition prior to the appointment or just even before, like not necessarily if the appointment happens. So this kind of allows you to assess where the patient is, any further kind of information, and potentially the urgency of the query that they might have submitted. Equally, we've got lots of dashboards, lots of bits of data within the Accurx function. So if you want to have a look at maybe how many requests have come in on a particular day, if this week feels particularly busy, it helps with that kind of workforce planning and capacity management as well. Equally, Dave, you touched on this, which is that proactive care. So using that shelf book for things like immunizations, reducing flu, remote monitoring questionnaires between consultations. So during winter, if you're seeing a higher case of perhaps mental health consultations, then those questionnaires may be like the GAD-7, the PHQ-9, checking in medication reviews in between, making sure that those patients know that there's a form of contact and kind of long-term, but also remote monitoring, almost preventative care or preventative in terms of any inbound requests that might be coming through. And then equally just kind of patient education on staying well during the winter. So that looks like things like perhaps a batch message saying we probably don't need antibiotics if you're getting things like a sore throat, maybe sensitive to light and things like that. I don't know, Dave, if there's anything you wanted to add onto the end of those.
Yeah, I think just in terms of the proactive side of things, we become a relatively reactive service over winter, and it is easy to forget that the things that we do proactively will help us because we get subsumed with so much demand. So one of the advantages of using the large scale messaging tools that we provide, and also the Florey's and similar, is that it allows you to do that at a scale that just really isn't possible working in traditional ways. So good examples of this are with respiratory illnesses over winter. So again, we'll talk you through how to do this in our demo in just a moment. But if you do have patients with difficulties with their asthma control, COPD control, these are things that can be reached out in advance because, again, it's a predictable part of winter. So historically, these are things that we've been reactive to. So people come in with their exacerbations, but actually looking at patients who, for example, have been overusing their salbutamol, who've had rescue packs in recent months, we can actually start providing them information about self-care, self-management plans that should hopefully prevent them coming to the point where they actually need some GP assistance. Although if they are, we still have the tools and availability to manage that inbound demand using things like the control questionnaires and similar. So we mentioned about mental health there, and I think as anyone else who's working in general practice at the moment will understand, it is an enormous burden, particularly over the winter. Interestingly myself, I rarely take people off antidepressants over the winter because it's just so miserable in the UK. But there are actually people who, on top of an already burdened primary care service, which is providing essentially urgent same-day care for lots of respiratory illnesses, will also need care at many points. So another group of patients where it's really, really easy to reach out to them proactively to check that they're okay, that they are aware of all the other services that are available. So it's remarkable, for example, how many people don't know about IESO or any of the self-help resources that are within regions. And you can do that within just a matter of moments rather than waiting for patients to come in a crisis. So you're probably detecting a theme about the whole presentation today, which is that we'd like to have crisis prevention, which is what a lot about of our proactive care side of things is, including both the batch messaging and self-book, immunizations being one particular part of it. Be interesting to see what Mr. Kennedy does in his role and whether or not that will affect the UK next year. But also in terms of just being able to manage that acuity, so when the crisis does happen, but with less burden because we've already done this work.
Oh, thank you so much, Dave. From here, we are going to go on to that live demo now. So I'm going to stop sharing and just flip my screen. So no one worry if you can't see any slides right now, that is expected. Brill. I'm just going to share this with here. And we should be good to go. So our example for today is going to be a patient who gets in touch, querying, well, they've got kind of a sore throat, cold, slight respiratory illness here. The first thing that they're going to do is call the practice. The practice, in theory, is actually very busy. Patient can't get through. So the first thing that they're going to do is go to the patient triage form. If I just open this up here. And you can also do this yourself to kind of experience what it looks like for a patient to send in a request. But we're going to get a feel of what it looks like for this patient to actually be reaching out to the practice, suffering from a respiratory illness, something that's super common this time of year. So me as a patient here, I'm just going to contact my Accurx practice and I want help for a medical issue. You'll see the first thing they get taken to is these red flag symptoms. And they have to confirm that none of these are present in order to continue with the form. Then have the opportunity to describe the medical problem. So in this case, this patient might have sore throat and a bit of a cough. They'll get asked how long it's been going on for. So in this case, it might be going on for 3 days, getting a bit worse. Tried anything to help? Perhaps they tried Lancet, lots of orange juice, the vitamin C there. Anything you're particularly worried about is an optional question, so they can skip this. How would you like us to help? I imagine that a lot of people might be putting things like antibiotics, please, worried about getting sicker. And then any best time to contact you. So anything that you need to avoid from the practice, or so for them, they might say something like, at 12 p.m, I'm doing a webinar. And they can continue. I can then go ahead and submit their request. And I've got my alter ego here, bannable likely, so I'll just be able to submit that. And I can then choose to go through here. Bro. That request has now been submitted, and I can hop back in to my Accurx toolbar right here. So you'll see that a notification will have popped up in my inbox. And if I click on that, I'll be able to go right to the unassigned folder where all of the patient triage requests will enter. First one that I've got here is our patient who hasn't done the verification and also is a dummy patient. So I'm going to have to search for them. From here, I can enter my patient's name. Select them, confirm. I now have the opportunity to save this to the record. And equally reply to the patient. You'll see all of these requests here are ones that have been submitted. And so perhaps we've got another patient here, for example, that has the exact same query, but maybe one is more urgent than the other. I do have the option to mark this as urgent if I need to. In this case, I've got this query that's come through that this patient's got a sore throat and a bit of a cough. I'm not too sure about the nature of their symptoms. I want to check a little bit further in terms of what's going on. In this case, I'm going to reply to the patient and send them a sore throat questionnaire. And I will check to see how they get on as from that response. And I know, Dave, you've mentioned before that often patients will actually kind of edit or amend maybe their responses here, or it might not always be highly indicative of what's going on. Is that the case?
Yeah, so interestingly, we were just having a discussion within the question answers about subjective responses to questionnaires. So patients do often reply, well, let's say perhaps in a slightly more dramatic way than their symptoms actually present in person. So this isn't an absolutely foolproof technique for this. However, it is more comprehensive than what we have in terms of both phone triage from a receptionist or just simply having people book directly in. So It's never going to be possible to get 100% accuracy on who needs to be seen versus who doesn't need to be seen. So the goal is reduction, not absolute exclusion, because if you were doing that and you were managing to exclude everyone who doesn't need to be seen, there's also a good portion of people who would do within that. So we have to take the rough with the smooth when it comes to patient reporting. But in fact, often what I find at this stage is that if I'm happy enough with where things have gone in terms of the information patients have given, they're much more likely at this stage to accept reassurances with some of the templates that we're going to share, that they don't actually have to come in. So even if you have a 5 to 10% reduction in your appointments that day, that's still a lot of appointments, particularly if, like on Monday, it was a particularly stretched day.
Absolutely. I think that a lot of these changes or recommendations that we have in terms of coping with winter pressures are very small or like minor adjustments. They can make a big difference and have a big impact, not just in terms of the capacity at the practice, but equally in terms of how the patient feels about how their care is managed as well. So they've got a response back, they have to complete this questionnaire, and that may also be an indicator of whether they're actually like kind of unwell enough to be concerned about it, especially in terms of that antibiotics question. Here we can also reply to the patient, presuming that they have responded, and say, actually, at this point, we're quite happy. Dave, you shared one of these templates with me where actually we can just send them some reassurance. So here we've got, hi, Banner. Thanks for completing our questionnaire. Based on your symptoms, I'm happy there's nothing serious going on and that this is a winter virus, which will need time to recover. Antibiotics won't speed things up. If you're at all worried, we'd be happy to see you, but otherwise rest, and following the advice in the link should get you better. So from here, we can actually attach that link, and that could be the nhs.uk advice link. And we could put in something like tonsillitis, add that in there, and have a look from there. Equally, we can choose to whether we say that, sorry, David, is that you're about to say something?
That's okay. I was just going to mention, just as you mentioned at the end of that reply, very specifically, I would generally leave the offer open to get seen if you're worried. Interestingly, because offering to see them if they're worried generally reduces the amount of people who ask for an appointment subsequently. So my experience, certainly working with other practices, has been where you say, thanks very much, you don't need to be seen. Inevitably, they come back shortly afterwards with an escalation of symptoms needing an appointment, whereas actually saying, I think you're okay, I don't need to see you at the moment, but we're happy to if you feel worse. People generally appreciate that, and it's got a much higher remote resolution rate than just simply slamming the door virtually shut.
That's really good insight. And would you normally allow a response then in this case?
Yeah, I nearly always do. So again, it's that perception of a consultation and a conversation with a clinician. So again, this lands particularly well if GPs are doing this, because patients appreciate having that discussion with you, because occasionally they may well come back with something that they've not mentioned before, and it actually is important. And if you just close the door on them, then it both feels quite brusque from a patient point of view. It's really easy to think, how do we get patients to help us? Well, we treat them like we'd like to be treated, and then they'll generally help us do what we're asking of them with some trust. If you're actually behaving like, nope, that's the end of the conversation, the resolution rate goes down significantly because recontact rates go up.
Well, and yeah, I guess it's also then less efficient, because if they get back in touch about the same problem and you have to go back and reopen it and check the notes, it's actually quite complicated. Whereas if it's actually, they can go back in directly into this thread, you have all of that information there. So it makes things a bit simpler if they do choose to respond at some point. I can send this over to this patient. There is also a scenario perhaps where our patient is actually quite unwell, and as a consequence of that flurry that they've responded to, we can then send a different type of template. So here we might have sore throat, needs treatment, which again is one that you sent over to me, Dave. So I know that this is a real one that is used in reality in practice. So in this case, we might be saying, hi, based on your symptoms, I'd advise treatment with a short course of antibiotics sent to a nominated pharmacy. If you're having trouble opening your mouth or drooling, please let me know in the response, as we need to see you in person. So again, this is that opportunity of creating that two-way conversation, but also asynchronously, so it's not taking any huge drain on time or capacity. So I can send this over And that's now with the patient, and they can choose to respond if they need to. If these are all complete, everything is actioned, I can then mark these as done. But what I want to show you as well is what this looks like just to set up those templates and kind of to get going. So to begin with, I'll just go to my initials on the toolbar and the drop down to manage organization. And right at the top here, we've got patient messaging. So people are typically familiar with the templates. And so you can create as many as you'd like from here. And this would be your template space. There's also workspace templates. So these are available across your organization. So within the practice, you can send those over. And if I choose to create a new one, for example, this one here, I could just say something like the winter pressures or winter respiratory illness, for example. And this could be going out in batch. I can organize these via category. So for example, batch message. And I can add in any additional content. So in this case, it might be there's winter illness going around. Often you don't need antibiotics. I know, Dave, that you have got a template for this as well, so I will flag that in a second. But something just to put into context here now. Equally, you can attach files, so that might be infographics on hand washing, instructions on how to stay safe during the winter, especially for those who are immunosuppressed, for example, wearing masks in the surgery, things like that might be relevant. So we've also got batch that we can tick here, and we can then save that template, and that will be available for me to then send via a batch message. I think that's all I've got to share today. I think we can move back to our slides. So again, we're going to have a quick change of scenery.
We had a question that we should answer live, I think, in the question answers, and it was about is the sore throat flurry particularly robust enough to end the encounter with an option to be seen? And I suppose that applies to all of them. So it's just worth touching on what's the difference between telephone triage and doing questionnaires. Probably not so much, possibly some clinical nuance, but in essence, sore throats particularly, because there's such a clear fever pain scoring system that you can use to determine antibiotic appropriateness, and also has flags for some of these serious red flag conditions. And again, within responses, you can do that, and I'll share some of my standard responses as well. They're actually it's quite useful to remote resolve, but in both ways. So both in terms of we can prescribe for you, and that applies to UTI quite frequently too, but with some safety netting, but also with the ability now to have self-book links limited to the same day, so that you don't have someone accidentally booking in 6 weeks in advance for something that you want to see them the same day for. It does provide that safety net. So in terms of just as a typical duty morning, so Monday morning was my morning this week, hooray, I was very happy at 8:05. I think I actually picked the phone up about twice in a whole morning, and we had, I think, 210 patient contacts by midday. So in terms of like what I actually need from people in responding, it's rare that I actually need to have a one-to-one synchronous consultation with them on the phone, because we get such good information from what we're sending them.
Absolutely. And I think that makes a lot of sense that you're kind of sending that information over as well. I'm going to touch on support and training, and we can go into a real deep dive with the questions, especially the ones that we're going to answer live. But if any of you are kind of curious as to where you can get more support or more training on these types of things, if there's any specific questions you might have in relation to your practice, for example, we have our support team via live chat. So that's on any of kind of the Accurx websites, or you can email them support@accurx.com. If you are after training, then customer.success@accurx.com is also a great option for you. And if there was something that we've mentioned in this webinar, a feature that perhaps you are interested in, contact partnerships@accurx.com if you're kind of keen for a quote. We have got some upcoming webinars as well. So on the 11th of December, it's going to be a new year, new workflows, how you can harness data to improve your practice. And once we are in the new year, 22nd of January, we've got Fragments 101. So just having cost-effective strategies for when it comes to messaging. We've also got our community. And so we've got a community page here. We'll include these slides in the follow-up email alongside the recording. So you can view upcoming and virtual events. And equally, a lot of information is shared within these community pages. So either via WhatsApp or via Facebook.
Hannah, would you mind popping your slides back on? I think it's just jumped out on the sharing option.
Thank you so much. Thank you. Well, hopefully we should be good now. You can see that, okay? Fantastic. Thank you so much for the heads up, Dave. In which case, I will go back and let you know that this is where the slides exist. So thanks for those who've joined. If you're looking, then they're going to be here. And like I said, the emails and everything will be included in the slides in the follow-up email. This is what's coming up next. And then this is our community page. So you can scan this QR code. Again, that link will be in the slides, in the follow-up emails. You can use it through there as well. You can join in on any of the discussions that are happening within these forums. Lots of questions get asked, and it's a really good place to have discussion. I know that I get a lot of ideas or tips from these kind of forums, so it can be really useful. Now we're on to our questions. So I don't know if there's any in particular, Dave, that kind of caught your eye that you were...
Yeah, I think some really pertinent ones here. So one of the questions from Lorna is this based on GPs providing information? Our GPs do not monitor Accurx. It is our admin team, and would this be acceptable? So the shorter answer is it would be, provided that there are internal structures. So this, again, think of this as no different to if you have your administration team doing telephones. So if admin staff are doing telephones, essentially they have to have some sort of structure to deal with inbound queries, so recognizing red flag symptoms, etc. My personal opinion on it is that it's a lot easier if GPs do it. There's another link question, which I'll come on to in just a moment, because you're just able to make such very quick decisions on things. So with the volumes that you get, particularly in winter illness spikes, it is, even if you don't do it normally, probably worth dedicating a GP to do this. One of the other questions was, will you lose all the appointments if a GP is doing this rather than admin? So, you know, on a typical day, the volume that you can deal with. So I was triaging on my own for most of Monday morning. So it was about 200 triage queries by midday. I did manage to get my lunch, and I didn't overrun my session. So I finished at midday, and I don't think that would be possible with administrators. So the trouble that happens then, if you do that, is it slows down the flow through the practice, it slows through the decision making. And actually, as we all know, if you're on a busy duty list later, then you end up just saying, could you just come in? Because it takes so much time to then secondarily triage something that admin have done, or actually just see them when they don't need to be seen. Any appointments that you would have lost by a GP doing this are completely dwarfed by the ones that you would save. And, you know, I've been doing this since 2017 now. So I promise I've made all the mistakes that I could have possibly made in terms of running these sorts of systems. And the benefit is very definitely there.
Well, was there any others that we're kind of looking at through here, or I guess any kind of responses to that as well, that we'd be keen in terms of answering live?
Yeah, so just having a little look through, there's some sort of similar themes coming out. So there's quite a few questions about whether templates exist. So just to clarify, these are some of the templates that we created for this, that were based on some of the ones in my practice, which we'll share. So that will be both within the Facebook group, and we'll share them within the Accurx users WhatsApp group. So if you haven't joined the Facebook users group, it's really worth doing, because there's lots of useful stuff that's shared there. And I'll also share, so I'm taking off my Accurx hat for a moment, I'll share the questionnaires that we use in my practice as well. So these include some slightly more definitive cough questionnaires, just to get a bit more information, because it's such a common thing over winter, and just some things that would be useful to you in terms of those templates. So no, the ones that we've mostly been showing you today have been user generated, but if you don't want to duplicate those, I'm more than happy to provide them. And I will also put up once again in the Facebook group the entire list of questionnaires that we've got for my practice, which I think is about 98 or something now, so it's quite a lot. They'll probably help a lot if you're doing triage, because essentially I've created one for everything that irritated me over the last few years. So I obviously get irritated quite a lot, and it really helps with the winter pressures too.
Oh, I think there's actually a couple that were actually directly addressed to you, and also your responses on some of the other questions. So there's one here which is effectively talking about the concern around missing things when it comes to remote consultation. So without face-to-face or without a phone discussion, or equally just kind of very specific concerns that it might be difficult to pick up on. What are your thoughts on that?
It's a good question, and one that I've heard a lot. So I can only tell you that in terms of the safety incidents that I've had doing this over the last however many years, I don't think we've had any. So in terms of things that were incorrectly triaged or missed, what I find really interesting about using asynchronous communication to the questionnaires, and I appreciate not all patients can do that, but that makes time for the ones who can't by using the phones for them. I just get such a lot better information from patients. It's interesting having those synchronous chats with people on the phone. They take a long time. The information's often quite rambling, and trying to divert people down those structured pathways that we need to do to have safe, robust clinical decision making is quite difficult. I think the other thing I would say that goes hand in hand with that is if there's any doubt, then it needs to be converted to a different mechanism of consultation. It's a minimal amount of people that happens to, though, but this is not something where we're deliberately wanting to make ourselves feel really uncomfortable with the decisions we're making. That's not the point. What you will find there is there are so many decisions that you can make that you are comfortable with because you've got such good information from patients. And don't forget, hand in hand with that as well, is the accessibility that you give to patients to both reply to you, to get back in touch with you, and the fact that by doing these sorts of things over periods of winter pressure, you'll actually have those appointments to give out to people or to direct them to other services like winter respiratory hubs. So, so it's a slightly lengthy answer, but in essence, if you do it as robustly as you do telephone triage, you'll find it both easier and just as safe.
Perfect. I also think there's a few people, so you'll see that my slides have moved slightly. There's a few people who are really interested in your questionnaires, Dave, the ones that you've created. So yes, join that Facebook group. There's also the WhatsApp group here. So this link, www.accurx.com/GP community, has both of those links that you can access. So either group. Equally, I wanted to just point out that people can also create their own templates or questionnaires. So if there was one question here that mentioned like a fear around like the kind of sore throat questionnaire and maybe like not including particular questions, that is certainly something that you can create and build yourself. And I know, Dave, that you've also got so many and that we've been plugging as well. Just having a look through some of the questions here now. Oh, we've got one here, which is how many complaints do you get from patients who might be unhappy about this?
Oh, yeah, none. So none at all. So like never. Honestly, it's an interesting challenge to our perceptions of what people want. And I think what they actually want is to talk to a clinician fairly quickly and make a decision that's sensible. So the mechanism of that doesn't seem to be particularly problematic. I mean, you do obviously have to be conscious about people who are either less able to do this or have expressed a dislike of doing it previously. So it's not something I would drag people down. The simplest way to think about it is like, what would you want from your surgery? So if you had an open, friendly discussion with someone who seemed very sensible and good at their job, then you're going to be happy with the response that you're getting, mostly. So we've never had a complaint generated from the use of this at all. I reflect back to pre-triage working like this. We got plenty of complaints from people where we were just full on the day or waited 40 minutes to be seen in the lunchtime clinics. So your perception of it is understandable, but it's really not what happens in practice at all. I think just on our patient survey questionnaires that go out, I think we've got something like 89% very good, about 10% good, and then the rest of it is something less than that. So if we were doing something wrong doing this, I'm sure they would have let us know by now.
I definitely agree that they would probably have flagged something at this point. I guess one of the other questions that might be quite relevant is there's obviously a lot of questions that have come through about these flurries that you've created. One of the things that I hear a lot is it's actually quite difficult to find the time to do this. So especially I think touching on proactive care. So I guess what I'm interested in is how do you factor that in and how do you kind of place that within your day and think about it like that?
Yeah, so I think doing this allows you to still do that proactive care. So just for some context about what's going on in the background in a practice that works like this. So we've for a long time had appointments limited at 25 appointments a day, and we rarely fill it, which sounds ridiculous, but it's true. And as people who've come to visit me, I've seen a couple in the questions have said. So actually, in terms of the managing that inbound responsiveness, it does allow the other clinicians much more time to carry on essentially doing normal duties that we expect GPs to do. So even on Monday, so it was not my finest day that I've ever worked, but we didn't cancel loads of other appointments and say, right, no, we can't have any routines today. We're actually just going to be doing urgent only, which again shows you how much you can actually manage with this type of both proactive stance, so telling patients, look, actually we're a bit tight today, and also having that slightly more robust triage at the entry point. So while we did see a lot of people with respiratory illness, it was certainly many less than we would have done in kind of traditional ways of working, where they probably would have just called in and they would have said, right, yeah, that needs to be booked into a acuity slot or similar.
There's also one here which is we tend to bring children in as blanket rule. Is your practice different?
Oh, hey Pete, nice to see you. Get into the question as well. I'm not sure it's a blanket rule. It sort of depends on what they're saying. So if someone is essentially questioning about a very simple, obvious cold, then I think we'd be happy with reassurances or similar for viral rashes and whatnot. We certainly have a much lower threshold for kids. So one of the things I'll share in my pack of questionnaires is an ill child questionnaire, which helps us work out. So before I made a decision to not do something with a child, to not bring them in, I'd certainly be wanting that information from them. And I think that goes, Pete, with the question you're asking about mitigating risk and similar, which is the more questions you get from people, the more information you get, the better your risk mitigation is. It's absolutely sensible to get as much information from people as possible. And this is a really, really good way of doing that. So you can get absolute prosaic responses from people in just a few seconds. And actually from a cognitive loading point of view, it's much easier for us to absorb written information than it is to absorb verbal information taken in auditory fashion. So I find it quite stressful doing that because you're trying to listen and process it as well. And lots of people are happy with those text responses, answering the question again, Pete, which was that because it's often a GP doing it, usually a GP in my practice, they're pretty happy that that's the case, and particularly, and I know I said it earlier, but leaving it open to them. So I rarely will say to people, you are absolutely not coming in, once in a blue moon. Normally the conversation ends with, if you're worried at all, just let us know. We're always happy to see you. And it's a surprisingly small number of people who actually then take up that offer.
Yeah, I think once they know it's there almost, it's more comforting. And perhaps that's also partially the reason that they're reaching out, especially when it's a minor illness and one that can be dealt with remotely, is knowing that there is support and guidance is enough, which I guess is the nature of those reassurance templates that exist. We've also got one here. So what are your conversation rates from face-to-face, telephone, in terms of reports? I mean, we have reports that would, like when you do the outcomes, but yeah, I'll leave that with you.
Yeah, so it's actually been really, really steady ever since I've done this. So roughly 30 to 40% are resolved sort of remotely with messaging, and then you split the remainder between in-person appointments. Probably the majority of in-person appointments, that's a personal choice, but if you look at data across the country, the remaining 60% is usually split 50-50 with phone versus face-to-face. I have a preference for seeing people in person because I kind of think that's a good mechanism, and it's the bit we enjoy. But that's roughly 40% is the almost always standard remote resolution. So the conversion rates are actually quite low. I think in terms of if when I've compared that, because I've in my history have done a lot of work with practices moving over to this, the telephone triage conversion rate is much higher than that. So that's why it feels like you're sort of double patting when you do a telephone triage, because often it's so pressured that it's just not safe to resolve it remotely, and people end up getting brought in.
Great. I think the questions have slightly slowed down now. I don't know if there's any that you've spotted that you're desperately eager to answer, Dave.
Yeah, so there's just one which we're going to answer live, which is about Charlie was just looking at the sore throat questionnaire. So the question was about how do we safety net for some of the sort of red flag symptoms and worst case scenarios. So that's something that I share in the response that I give to people, both in terms of like the explicit text within it, so like specifically talking about things like drooling, etc., but also with the linked NHS guidance as well. And again, leaving that response open. So once in a blue moon, someone actually does come back and go, oh yeah, I've actually got that. So it's similar concepts to, you know, how do we finish off any consultation? We safety net it as we normally do. So I would never complete a consultation based on essentially a single inbound message with no right to reply from a patient and no advice from me. Treat it as if you're doing it in person, because that's essentially a conversation, and that's how it makes it safe.
Well, thank you so much, Dave. Before I kind of wrap this up completely, what I'm going to do is, again, just flag this community page. So there's the QR code here, and equally, we've got the Facebook groups and the WhatsApp groups on that link. So please do follow it if you are interested in getting those flurries, and equally just having a chat about whatever it is relating to Accurx.
Yeah, and we've got a patient survey, a survey for attending today as well. So if you could fill that out, that would be great. Just let us know how the webinar went, and over the winter, if there's other things that you'd like us to cover, we'd be very happy to do so. So just reiterating the points from earlier, that within the link that we shared earlier and put it onto our socials, is that the Facebook group and the Accurx users group on WhatsApp, we'll put those information packs out in both in terms of the templates, the questionnaires. A couple of GPs in the responses have also said they'd be happy to share theirs. So thanks, Chris, and we'll make sure you have a good winter with it.
Great, thank you, everyone. I'm gonna just go on mute now. There is a poll now available for you to fill out. So if you can, please do. If not, there's some time back for you. And keep an eye out on your inbox. We'll have that follow-up email alongside that recording right to you. Cheers, everyone. Right, now we've got a few poll results. So I'm just gonna stop the recording.